Hello, everyone. Welcome to Is Pharmacology Difficult podcast. And today it's a very special episode. I have with me our special guest, Dr. Tristan Leonard. He's a specialist anesthetist and educator. He's executive producer and host of Dr. Tristan Anesthesia tutorials. And he has also a website and a YouTube channel of his own. Would you like to add something, Dr. Tristan, about yourself?
Hi, Radhika. Good evening. Thank you so much for having me on. Yes, my name is Tristan, so I'm going by Dr. Tristan Leonard. I'm a specialist anaesthetist. I've been a specialist or consultant in South Africa for 6 years. I never say no to anything, so I have ended up doing neonatal anesthesia, transplants, pediatric neuro, cardiac, all of those things. And I've been thinking since about January about a podcast and teaching. And I looked in my folder and I have about 120 presentations that I've given over the last 5 years.
Wonderful.
And I just thought, well, why not put this out there? And then, like I said, I kind of self-taught on a few tutorials. I figured out how to use YouTube and TikTok. And I used some of my younger nieces and nephews, and they educated me. And the channel's been live for 14 days, and it's doing really well. And it's a great honor to be for this to be my first appearance on somebody else's podcast. So thanks so much.
That's wonderful. And I would like to congratulate for especially the wonderful channel growth and recently. And may you achieve many more. And now we'll get on with our topic for the day. We'll be discussing the general anesthetic agents, especially the inhalational and the intravenous agents. I would like to share my slides. So I'll be just sharing my slides. Okay, so our topic for the day is anesthetic agents. First of all, we're going to talk about the anesthesia. What is anesthesia? So, can you see the slides, Doc? Yeah, now I can
Yes.
see them. So, reversible loss of response to a noxious stimuli. That is a very brief kind of definition and very apt definition of anesthesia. General anesthesia is always associated with the loss of consciousness, while local anesthesia, that is the difference in that the consciousness is maintained. And what about the term balanced anesthesia? It involves unconsciousness, analgesia, muscle relaxation, and abolition of compensatory reflex responses. Now we'll be talking about a little part of the history of anesthesia. So in that, I'll be showing Dr. Tristan's slides. So just a second, I'll be just sharing his slides now. Yes. Are they visible?
Yes.
They'll be just. Yes. Okay. So we'll come over to the history part.
Yes. So
Okay, would you
if you
like
have a
to
look at
explain? Yeah.
Sure. So if you have a look at that slide there, that's showing a demonstration of ether, and it's for a dental procedure. And this is around 1830, the early 1840s. And this was the first use of what we have come to know as volatile or inhalational anesthetic agents. So it was chloroform and ether predominantly. And if you go to the next slide, we can look at
Yeah,
the
I just
years
got
that
this.
these drugs came across, or these vapors came across. So, as I said,
Yes.
you start in the early 1840s, where we had nitrous oxide. Remember, the understanding was they understood that nitrous oxide was a good analgesic, but they didn't realize that that if you administered pure nitrous oxide, you could make a patient incredibly hypoxic and potentially kill them. So nitrous fell out of favor for a period until it was understood that you needed to add supplemental oxygen. But then
Exactly.
ether and chloroform were used for almost the next 80 years or so. They were the predominant volatiles. And I always like to tell the story of Queen Victoria, who Jon Snow, I love the name, from Game of Thrones, was her anaesthetist, or the early version of what we would know as an anaesthetist. And he gave her ether during her labors of, I think it was Prince Leopold. And the church was initially very opposed to this because the pain of childbirth was seen as a sort of virtuous suffering. But being the Queen and being Queen Victoria, of all people, they weren't going to say no to her. And that sort of popularized ether. Once the Queen had done it, it became quite a common analgesic. And then, as we see, we then waited quite a while before we started getting to the mid 1920s, 30s with cyclopropane, trichloroethylene, etc. The problem with all of those is that they were all incredibly flammable and volatile and explosive in some instances, especially cyclopropane. There were instances of vaporizers exploding, bottles exploding if they were dropped, etc. So we had to wait until we got halothane in about 1960, where the true volatile, inhalational, safe anesthetic that we've come to know came from. Halothane had its problems, halothane hepatitis in particular. It's an autoimmune response to repeated exposure to halothane, unfortunately predominant in middle-aged women. And those are the type of patients who often come for multiple anesthetics. So we then moved on to enflurane, which was great, except it was still flammable. So then isoflurane, desflurane, and sevoflurane came along. And it all sort of depends on the resources in your country. In South Africa, halothane is not available anymore. So isoflurane is the sort of cheapest volatile. Um,
Yes. Right.
but in most hospitals, we will be using sevoflurane and desflurane in the vast majority of anesthetics, at least that I do now, and in most hospitals around the world. Some places will still use isoflurane, and even though halothane was cheap, the problem is that the vaporizers are all 40 years old, and nobody's going to make you a new vaporizer for halothane. So, so it's kind of, I think they still do use halothane and isoflurane for veterinary anesthesia, as far as I know.
Okay. We'll go to the one more slide there is. So,
Yes.
would you like, is it covered or should
Yes.
we?
So, like I said, there was chloroform that I spoke about. And as we
Yeah.
said, nitrous oxide was the earliest used, but it was only sort of properly understood about 70 years after it was actually first produced. So in 1772, but they kind of only stopped being fairly dangerous about 70 odd years later. But as I said, chloroform and then ether became by far the most common anesthetic for the next 80 years or so.
Okay. Okay, so that was a wonderful history and examples given by Dr. Tristan. Now I'll
Thanks.
be sharing some more information that we should know about the introductory aspect of these agents. Okay, so this is a little information that we should know, a brief introduction about the cylinders in which they are stored, and then via the Boyle's machine, the inhalation agents, they are delivered to the patients. There is a color coding of the cylinders. So as you can see, the different gases have different color coding of the cylinders, like nitrous oxide blue, cyclopropane orange, air gray body with white shoulders, oxygen black body with white shoulders, carbon dioxide gray, helium brown, and anthrax blue body with white shoulders. Similarly, there is also another thing that is a pin index system. That is for the safety. So there's a pin index for every of the gaseous agent, these inhalation agents. So for air it's 1.5, for oxygen 2.5, then nitrous oxide 3.5, carbon dioxide more than 7.5% concentration, it's 1.6. Less than 7.5% concentration carbon dioxide, it is 2.6. Cyclopropane 3.6, anthrax 7. So sometimes for some of the important agents, these are important, though it should be in your knowledge that these things do exist. Now we come to the important aspects. We're going to talk about some important terms which are very, very important. So I'll give a brief overview and Dr. Tristan will add over these. First of all, minimum alveolar concentration. A basic definition is the minimum concentration of an inhalation agent required in the alveoli to produce unresponsiveness to the skin incision or any kind of incision in 50% of the patients. That is the definition of the MAC for that particular inhalational agent. And what is the significance? It is the measure of the potency of that inhalational agent. And how do we measure it? Greater the value of the MAC goes, lesser is the potency. It is indirectly proportional. Yes, Dr. Tristan, would you like to add something now?
Yes, exactly. So thanks. So as you see there, we described that's the issue we found with nitrous oxide, for example. So nitrous oxide has a MAC of 104%, which means you would have to give a patient pure nitrous oxide at an increased pressure to achieve 104%, and they would die immediately of hypoxia. So that was what was found when they were trying to do anesthetics in the late 1700s with just nitrous oxide, was they couldn't get a deep enough level because it is the least potent. So if we then look at the modern agents, the most potent is isoflurane, because that has a MAC of only 1.2%. And then desflurane is the least potent with 6%. But what we use in anesthesia is that the higher the MAC, the quicker they wake up, the more quickly the onset and offset. So even though desflurane is less potent, patients go to sleep quicker and they wake up much quicker from desflurane as compared to isoflurane.
Right. Now, the next thing that we should know about, the next important thing, is the blood gas partition coefficient. Now, this is also a very important aspect and property of the inhalational agents. It is determined by the solubility of an agent in the blood. It determines the speed of onset and recovery of an anesthetic agent. Again, it is indirectly proportional. Greater the blood gas partition coefficient, lesser is the speed of onset and recovery. Yes. Now, would you like to add something, Dr. Tristan?
Yes. So exactly as you're saying, is that remember that, and this is a concept that sometimes my interns or registrars struggle to understand, is that how can a drug that's less potent have a more rapid onset and offset? But what you need to understand is that this is the only drug that's a gas in anesthesia or generally in medicine. And so its property is achieved by its partial pressure in the blood. And if you remember, Henry's law says that the more soluble or less soluble a gas is in the blood, the greater its partial pressure. So by being very insoluble, you create a much quicker and higher partial pressure in the blood. And so you then get a higher concentration in the brain. And then the opposite is true. So the greater the gas partition coefficient, the more soluble the gas is in the blood, it takes a longer time to build up a high enough partial pressure to achieve the desired action. So it's just that concept of understanding how these drugs work as gases, not as an intravenous bolus of another drug that we might be familiar with.
Exactly. Very nice explanation.
Thank you.
Now, uh, now I'll be just sharing some properties of an ideal anesthetic agent. They are different for the 3 different individuals who are involved in the whole process. So for the patient, it should be pleasant, non-irritating, should not cause nausea or vomiting, and there should be a smooth induction and recovery, and fast also, and there should be no after effects. For the surgeon, it should be able to provide a very apt analgesia, immobility, and muscle relaxation. Especially, it should be non-inflammable and non-explosive so that the cautery can be used. And as far as the anesthetist is concerned, I will tell you, but more light will be thrown upon by Dr. Tristan. Its administration should be easy, controllable, versatile. Margin of safety should be wide. It should be potent, low concentration so that it should be used. Rapid adjustment in the depth of anesthesia should be possible. It should be cheap, stable, easily storable. It should not react with the rubber tubing and soda lime. Anything else would you like to add, Dr. Tristan?
Yeah, so I just think it's interesting you've listed them all comprehensively, and if your listeners or you and I are sitting thinking of, well, which gas or which drug kind of fits this, we compromise on a lot of things. So desflurane is rapidly titratable, etc., but it requires a separate vaporizer, and it's more expensive, And then propofol is very easily titratable, and but then it requires pumps with special algorithms for infusion. So we can never quite achieve one. And if you put 10 anaesthetists in a room, we'll argue about whether giving gases or volatiles or propofol infusions, etc., which is better. And we'll never quite get the final full answer,
Right. That's very interesting. Okay. So, after this, a little briefing about the classification. So there are basic heads. There are 2 types of anesthetic agents: inhalational and intravenous. Under the inhalational head, we have gaseous agents and volatile liquids. See, there should be a nicely demarcation, like gases and volatile are not the same thing. The basic thing is gas at the room temperature, it is a gas, while volatile agents, they are liquid at the room temperature. So this should be very clear in everybody's mind. Only one gas is there, nitrous oxide, and volatile liquids involve ether, halothane, isoflurane, desflurane, and sevoflurane. Then intravenous, they can be fast-acting agents and slow-acting agents. Fast-acting involves thiopentone sodium, methohexatone sodium, propofol, etomidate. And slower-acting agents, they are benzodiazepines, opioid analgesics, and for the dissociative anesthesia, we have ketamine. So, first of all, I'll be just briefing around and with the different agents, and meanwhile in between, the light will be thrown upon by Dr. Tristan. So first of all, I'll brief about nitrous oxide. That's the first thing. It was also known as laughing gas. It's colorless, non-irritating, non-inflammable. The color of the cylinder is blue. It's a very good analgesic but weak anesthetic agent. You have been explained because its MAC is very high. It's a poor muscle relaxant. It shows faster induction and recovery, and it is used in concentration of 50 to 65% with 33% oxygen, while Antonox is a mixture of 50% nitrous oxide and 50% oxygen. Yes. Now, Dr. Tristan, would you like to add something about it?
Yes, so I think the most important thing, Radhika, just to emphasize with nitrous oxide in particular, is the effect of barometric pressure on its effects. So in South Africa, for example, where I am, Johannesburg, is about 1,500 meters above sea level on what we call the high veld. So you won't find nitrous oxide being used in pretty much anywhere up where I am. I did my internship in Cape Town, obviously at sea level, and there we did use nitrous at about 60 to 65% as an analgesic, combined with oxygen and a little bit of sevoflurane. And one area where it does work particularly well, as you've said, is if you have to do a general anesthetic for a cesarean section, the analgesic effect of the nitrous means that you can give much less opioid until the fetus is delivered. And so you get less respiratory depression and all of those effects. And then Entonox in Joburg, Durban, on our coastal regions and countries that are low-lying is an excellent analgesic for dental procedures and for labor analgesia. But as I said, up where we are, there is a debate. It's not really used, and so a lot of new hospitals are not even putting nitrous tanks and pipes in, because out of all of the gases that we use, it is a particularly bad greenhouse gas, and you have to use it in concentrations greater than 60% to achieve any effect. So there is a movement, even within anesthetic circles, to say we've got sevoflurane, we've got desflurane. So besides Entonox, should we really be even using nitrous oxide in theatre? And I tend to be sympathetic to that argument.
Okay, that's a nice information. Thank you. So, three kinds of effects they are seen with the nitrous oxide agents. Concentration effect, that means when they are administered in high concentrations, due to high concentration, diffusion hypoxia and second gas effect are also seen, especially with the nitrous oxide. Second gas effects is seen when another inhalational agent like halothane is administered along with nitrous oxide, and due to the generation of negative pressure, the second gas is also taken from the cylinder. And on the diffusion hypoxia, that is when the supply of N2O is stopped while recovery, then it can be prevented by 100% oxygen for a few minutes before discontinuing nitrous oxide. So these are important things. Other side effects are methemoglobinemia, laryngospasm. They may occur with nitrous oxide. So these are the important side effects. Now I'm going to talk about halothane. Halothane is colorless volatile liquid. It is non-irritant, non-explosive, pleasant smelling, stored in around amber colored bottles, and it's a good anesthetic but very poor analgesic agent. It can cause hepatitis on repeated use. There's also a condition called as malignant hyperthermia, abbreviated as capital MH. It can be treated with dantrolene, and it can result in post-anesthetic chills, shivering, and for that particular thing, pethidine is used for the treatment. Then next important point, halothane can relax uterus, and due to this property, it is the agent of choice in internal version and manual removal of placenta. It is sometimes also contraindicated in labor. That is because this property can also prove negative sometimes. And it sensitizes the heart to arrhythmogenic action of catecholamines. So it is contraindicated in patients of pheochromocytoma. It is also a cardiodepressant, and it can cause bradycardia, arrhythmias. It is the inhalational agent of choice in bronchial asthma due to bronchodilator action, and it is very excellent for induction in children. And now Dr. Tristan will throw some light regarding especially the MH. I am sharing your slides about it. I think
Sure.
you have some material there.
Yes. So, as you say, halothane, it definitely smelled the best. It had the sweetest smell of all of our volatiles. So it was the best for inhalational inductions in children. And I remember having my tonsils out when I was a child, and I still remember the sweet smell of halothane. The problem with it, as you say, is that repeated exposures, we do have issues with halothane hepatitis, and we do also have issues with it was arrhythmogenic. So it would, in patients who were predisposed to abnormal heart rhythms, especially those with perhaps ischemic heart disease or tachyarrhythmias, it was an issue. And then, as he said, the halothane was discovered to be a trigger for malignant hyperthermia. So malignant hyperthermia is a genetic disorder that is inherited often as a sporadic mutation, but often in an autosomal recessive pattern as well, whereby there's an issue with one of the receptors called the ryanodine receptor on the sarcolemma of the muscle cells. And basically, when exposed to, in particular, halothane and sevoflurane, less so with desflurane, because desflurane, as we said, is so insoluble that there's only a tiny little bit of it in the blood, but we would avoid volatiles in anyone who has a risk or history of MH. They basically get a massive, unregulated, disproportionate release of calcium from the muscle, and that then causes apoptosis and eventually causes rhabdomyolysis, arrhythmias, hyperkalemia, hyperthermia, etc. And it's often picked up in theatre, even though the name says malignant hyperthermia, that sign develops about 30 minutes or an hour later, maybe. So the first sign is actually that their carbon dioxide level shoots up because their whole body is now incredibly metabolically active, and they have an unexplained sustained tachycardia above 150. And then, as you say, the treatment is to cool them down, to get rid of the volatile, because as you keep giving the gas, it will keep triggering the response. So you switch them immediately to propofol sedation. And then dantrolene is a special calcium channel blocker that will need to be given as a bolus dose and then as an infusion to over sometimes up to 72 hours after the event. And the one scary thing about malignant hypothermia is that only about 50% of them, so about half, present in theatre. The other half up to half can present a day after an exposure. And the second scary event is that just because somebody, let's say, has a family history of malignant hypothermia, but they say to me, oh, but I had an anesthetic when I was 8 for my tonsils and there was no problem, it doesn't mean necessarily that it's safe. So because in this day and age doing a propofol infusion is so available, we would elect to do what we would call a trigger-free anesthetic with all of those drugs as we listed on the other side. So propofol infusion, maybe a little bit of ketamine, dormicum, and opioids.
Right. Very, very nice information.
It is, though, sorry, just to say, it is incredibly rare. So in my whole career, I've only seen one. And there are some anaesthetists who will go their entire careers and not see a true malignant hypothermia. We often see conditions, what we would call AIR, so anesthetic-induced rhabdomyolysis. And that's kind of an unclear side effect of what the exact cause is. And that's far more common than a true MH.
Exactly. Yes.
Yeah.
That's a wonderful elaboration of the whole concept.
Thank you.
Now, I'll be talking about other drugs. Next, I'm going to talk about isoflurane. Isoflurane is an isomer of enflurane. It is not a good analgesic agent. The cardiac output is maintained with isoflurane, therefore it is the agent of choice for cardiac surgery. It produces least increase in intracranial tension also, so it is a very good agent of choice for neurosurgery also. It produces maximum decrease in blood pressure, so it is the agent of choice for producing controlled hypotension also. And then it can be used in daycare surgery. It is very safe in pheochromocytoma, and it can cause coronary steal phenomena. Yes, so these are the points. Now we'll be talking. Dr. Tristan, would you like to throw some light about this one, isoflurane?
Yes.
Anything?
So I used isoflurane early in my career, as I said, as it became, as time's moved on, it's become less and less common. In South Africa, you'll find it at smaller hospitals in more regional or rural areas. It's a great anesthetic, as I said, quite potent, a MAC of 1.2%. The biggest issue with it is that it's really smells terrible. So the patient has to be quite deeply anesthetized with propofol or something like that before they will tolerate isoflurane. And in kids, around like flu season and things like that, all kids have sniffles and snots and coughs and colds. And if you're doing a list with isoflurane, it can be an issue with even if you're giving them an intravenous induction, that's causing bronchospasm, laryngospasm. And then the coronary steal phenomenon, it's been debated so much. By causing coronary vasodilation, you could potentially divert blood away. And then there's a very shame, she's departed now, but a classic anaesthetist from my institution, Professor Peltz. She was the neuroanaesthetist, and she believed that isoflurane to her dying day was the best inhalational for neurosurgery. And, if you look at the evidence, it does have the lowest, it drops ICP the most, it drops cerebral oxygen consumption the most, it even causes a reduction in CSF production, so it drops ICP from 2 mechanisms. So, we don't have it anymore, but I certainly used to use it because of neurosurgery in those patients, because of her. Now, unfortunately, as I say, I haven't seen an isoflurane vaporizer in about 5 years around here.
Okay, that's a long time. That's a pretty long time. Okay, that's nice information. Now we'll go to desflurane. Desflurane has minimum blood gas partition coefficient. It is the fastest inducing agent. Very high vapor pressure. The boiling point is about 23 degrees centigrade. It boils at room temperature. It requires special vaporizers for this particular property. It produces cardiovascular effects, and it does not produce coronary steal phenomena. Induction with desflurane is quite unpleasant. It causes maximum irritation to the airways. It can lead to coughing, breath holding, laryngospasm. It is also used in daycare surgery. So that is all from my end. Anything you'd like to add up?
Yes, so as I say, I always joke desflurane is my favorite volatile or inhalational, if you can have one. Especially, in South Africa, in the private sector, patients pay per minute that they're in theatre. So time is money, so to speak. And the speed with which desflurane works is just brilliant. So patients wake up rapidly, clear-headed, and it's an agent of choice in patients who are obese. And we do obviously have quite a big obesity issue in South Africa and globally because of the rapid wake up. They get less airway obstruction and those things. People do argue, we'll talk about it, as you said, about the environmental effect, about, it isn't great for the environment, but it's used in very small amounts and it is scavenged by the hospital scavenging systems. So it's really, for me, it's a volatile, it's cardio stable, it really just works well. The only quirk about it is you can't put a patient from 0 to 12% desflurane rapidly because it does have a side effect of causing a tachycardia. So we use the rule of 16. So if your flow rate times the desflurane concentration should never be more than 16. So if you've got a desflurane concentration of 8, your maximum flow rate should be 2 liters, for example. And by doing that, it prevents you getting that tachycardia. And then lastly, as you said, great for daycare surgery because patients are awake and ready to go home within an hour or two after their surgery.
Exactly. That's a great information about desflurane. Now we'll talk a little about sevoflurane. It is the inhalation agent of choice for induction in children. Very good muscle relaxant, but poor analgesic agent. It should not be used in closed circuit. It can produce nephrotoxic metabolite compound A. What else would you like to add, Dr. Tristan?
Yes, so sevoflurane is the most pleasant smelling of the volatiles that we have. And I do lots of, about 60 to 70% of my practice is pediatric anesthesia, so I'm very familiar with sevoflurane. So it's the one instance where I may use nitrous oxide very briefly, where I will combine oxygen, sevoflurane, and nitrous oxide using the second gas effect, whereby adding nitrous oxide it causes a faster induction. But even without the nitrous, it smells pretty pleasant. If you make a game with the kids, we put vanilla essence around the inside of our masks so that they smell sweet. And if the high doses or the high concentrations of the SIVO, some kids swear to me it smells like bananas. So I've never smelt it like that, but I tell all the kids now, you must tell me if it smells like bananas. Also a great drug, cardio stable, pretty rapid wake up, and a lot of anaesthetists who are sort of a little bit worried about the cost and the environmental impact of desflurane will use sevoflurane for all of their anesthetics and have absolutely no issues. Maybe I'm just a little bit impatient, but I like the quicker wake up with desflurane. So a lot of the time I will induce with sevoflurane, put up the drip, and then actually switch to desflurane for two reasons. One, they wake up quicker, but number two, sevoflurane in children is particularly implicated in emergence delirium, whereby kids from the age of about 18 months to about 6 years wake up very distressed, agitated, unable to be calmed down for about 15 minutes. And it's not due to pain or anything, it's just a side effect of the anesthetic. And I have found, just in my personal practice, with not much literature to back me up, but I do a lot of these, that if I use SIVO and then switch to DES, I get much, much less emergence delirium.
Very good. That's a very nice clinical pearl that you have shared with all of us.
Thanks.
That's a great information. Now I would like to talk about cyclopropane. Cyclopropane is, as it has been told, it is highly inflammable and explosive agent. The color of the cylinder is orange. It's an inhalation agent of choice in hemorrhagic shock because it increases the blood pressure by increasing the sympathetic tone. It should be stopped very slowly because sudden discontinuation may cause a cyclopropane shock, that is kind of a hypotension. Anything else would you like to add?
Yeah, so as I say, I mean, cyclopropane very, very rarely used these days. And it was predominantly because, as we said, of those cardiac side effects, unfortunately.
Right. Now I would like to talk about xenon. Xenon is a Greek term for stranger. It was discovered in 1898, found to be only noble gas to be anesthetic under normobaric conditions. It is extremely scarce with an average room containing only 4 ml. And we call xenon as an ideal agent. Now there are certain reasons to call xenon as an ideal agent. Because it is colorless, odorless gas, it has no irritation property. It is well tolerated. It has lowest blood gas partition coefficient that allows rapid induction, reversal of anesthesia. It produces unconsciousness with analgesia, a degree of muscle relaxation also. The MAC is 60 to 70%. That allows a reasonable inspired oxygen concentration. It does cause respiratory depression and it has no effect on cardiovascular function. It is not metabolized in the body, eliminated rapidly, completely via the lungs. It is non-toxic, not associated with allergic reactions. It is quite stable in storage, non-inflammable, but the major problem is very expensive and routine usage is not possible because a closed circuit delivery is I think it's not, generally it's there, closed circuit delivery system. Yes. Now what else should we know?
Yeah, so the issue with xenon, it's mainly only really in experimental or research areas. Because it's so expensive, you need a totally closed system, and we don't have those. So we use a circle system in anesthesia, but we still add a lot of fresh gas to that. To add that much xenon costs a fortune. And then secondly, as you said, the max about 60%. So anybody who needs more than 40% oxygen, you've got a problem. So it hasn't really filtered into clinical practice. And then in the few of the sort of case reports that I've read about it, they've said that it seems to have a very high incidence of post-op nausea and vomiting. And that for some reason that they can't figure out yet, it causes men to become agitated if you try to do a gas induction with xenon. So as I said, just sort of it's theoretically ideal, but far too expensive and cumbersome to be in clinical practice yet.
That's great information again. Okay, thank you for this one. Now we'll go to intravenous agents. Now I would like to say that some of the things which are not used, strialine, then chloroform, then methoxyflurane, they are not much in use. So we'll be talking about intravenous agents now. In that one, first of all, we are talking about the fast-acting agents. The first one is the thiopentone. It's an ultra-short-acting barbiturate, the most commonly used intravenous inducing agent. It's used as a 2.5% solution. Sulfur is added to pentobarbital to increase the lipid solubility. And because of the high lipid solubility, it's a very fast-acting agent. The action of this drug, it terminates also very quickly due to redistribution. Then it is also possessing anticonvulsant action. Another barbiturate, methotrexate, increases the risk of convulsions. So that has a different use, like electroconvulsive therapy. Then another point, it is the agent of choice for cerebral protection. Why? Because it decreases the cerebral oxygen consumption and also decreases intracranial tension. It causes peripheral vasodilatation and also depresses cardiovascular system. So sometimes it can lead to hypotension. Now, instead of producing the analgesic effect, it can produce sometimes hyperalgesia. Respiratory depression and other problems are sometimes seen with this agent. There's also one more point on accidental injection of thiopentone in the arteries. There can be problem of thrombosis, vasoconstriction that can lead to ischemia and gangrene also. So we have to leave the needle in situ for this particular condition. The needle should not be withdrawn. Dilution with saline, immediate heparinization, piperine injection, etc. should be done. Then they are absolutely contraindicated in acute intermittent porphyria. Now, what else would you like to tell us about it?
Yes, so again, unfortunately, thiopentone, very, very hard to get hold of. Most of the time these days, if you want a barbiturate, you're going to need to get phenobarbital. And it's an unfortunate reason. One of it was less demand. Once propofol came along and the new formulations of propofol that don't burn so much and that are safe for infusion, it fell out of favor because it does have a long hangover time. So you do wake up feeling very groggy from a thiopentone anesthetic. But for neuroprotection, there is no better drug. And nowadays, so we used to give patients about 2 to 5 grams of thiopentone to induce a barbiturate coma if they had severe head injuries or raised intracranial pressure. Now my understanding is that they use phenobarbital to achieve that. And a morbid reason for why we don't get thiopentone is thiopentone was the first drug of choice in the cocktail for the lethal injection in the United States, and I'm sure in other countries. And the European drug manufacturers, the sentiment to the death penalty is very different in Europe to America. And so they stopped supplying the thiopentone to the states in the US that had executions. And so the demand dropped off so much that it's now not available. I do know that vets still get it because it is much, much cheaper than propofol. That it is used a lot in veterinary anesthesia and in much poorer resource-constrained settings. But it works well. I used it at the beginning of my career. I used to often use it in pregnant patients who were pre-eclamptic or eclamptic, who had seizures and hypertension to induce anesthesia.
Yeah, I would just like to say the video is a little I think it got stuck. So
Okay.
just see about it. Now, that's a great information about this thiopentone. Now, a brief about methotrexate, quite a similar drug, ultra-short-acting barbiturate, but 3 times more potent than thiopentone. It induces seizures, so it is the agent of choice for electroconvulsive therapy. Yeah, now it's fine. Yeah. So methotrexate, the same explanation, something extra you would like to tell?
Yeah, so as you say, it was the drug of choice for ECT, for inducing seizure activity, but again, only now really used in experimental or research settings, not commonly available in anesthesia anymore.
Okay. Okay. Now we come to a very nice important drug, ketamine. Ketamine is a hallucinogenic phencyclidine derivative that is administered in a dose of 2 milligram per kg. Its onset of action is 30 to 60 seconds, whereas action terminates in 15 to 20 minutes due to redistribution. Then it acts by blocking NMDA receptors of glutamine. It's a very strong analgesic agent but lacks muscle relaxant property. It is used for producing dissociative anesthesia. Now, I would tell you what is dissociative anesthesia. A state of profound analgesia, amnesia with a very light sleep, immobility. One feels dissociated from one's own body and the surroundings. Then next point, it does not depress pharyngeal and laryngeal reflexes. It is the agent of choice for emergency anesthesia with full stomach. Then that is the reason, because vomiting will prevent the aspiration. That is one important reason behind this. Next important point about ketamine, it will increase all the pressures. Means blood pressure, intracranial pressure, intraocular pressure. So it's the intravenous anesthetic of choice for shock. And it is contraindicated in glaucoma and head injuries. It's a powerful bronchodilator agent. So very good anesthetic of choice in bronchial asthma. But then we have halothane also, especially for the bronchial asthma, we have halothane, that's another choice. It's the intravenous anesthetic agent of choice for induction in children. And then we have a comparison with sevoflurane here. The next important point on discontinuation of ketamine, emergence reaction can occur, some adverse effects may be seen. Hallucinations, they are most common side effects, and other things are illusions, excitement, etc. Yeah, what else would you like to tell us about ketamine, Dr. Tristan?
Yes, so ketamine is a drug. It sort of falls in and out of fashion, and it's very much in vogue at the moment. So it first came to fame in the first Gulf War because it's a total anesthetic. It's the only drug we have that gives you anesthesia and analgesia at the same time. So for patients, unfortunately, whose leg has just been blown off in Iraq or Afghanistan or wherever it might be, who's been shot or whatever, in our setting, a patient who's been in a motor vehicle accident, etc., it's a great drug because it gives you sympathetic stimulation and it keeps your blood pressure up while they do the sort of damage control surgery or the resus or whatever. Just a note on that, though, is that if you have a patient who's been chronically ill or who's at the maximal end of their sympathetic stress response, ketamine's direct effect on the heart is to be a depressant. So if you don't have enough of your own endogenous catecholamines, you can get a bradycardia from ketamine. We love it in kids because, as we say, it prevents bradycardia, which is what kids often get with anesthesia or hypoxia. And then, as I said, on my channel, I've done the talk on peds cardiac anesthesia and cath lab. And ketamine's a great drug as a pre-med or as an induction because it maintains your blood pressure and it maintains your heart rate. So even if the child has a shunt, it keeps the shunt pretty stable. And then I'm sure you're aware, Radhika, that as an antidepressant, ketamine has found new fame. So unfortunately, I spoke to a psychiatrist, colleague of mine, and I said, what is the deal? Because, the buzz last year was amazing. And then Matthew Perry died. Remember, he drowned in his hot tub after taking ketamine. And she said to me that the initial results were spectacular, but the length of time that it lasts seems to be getting shorter and shorter with each time you take it. And in Matthew Perry's case, he got his prescription ketamine in the morning, and it wasn't enough, and he took his illicit ketamine in the evening and passed out and drowned in his hot tub. So it's controversial from that point of view, but as an anesthetic for unstable patients or for kids, it's a phenomenal drug. And in low doses, it prevents chronic pain as well, which is an excellent issue in patients who have chronic pain problems.
That's great. That's a very nice example and information about ketamine. Now I would like to talk about propofol. Propofol is a milky white powder that is preservative free. It must be used within 6 hours. It's an oil-based preparation. Injection is painful. The onset of action is within 15 seconds, lasts for 5 to 10 minutes due to redistribution again. It possesses very strong antiemetic, antipruritic action. It decreases blood pressure, impairs baroreceptor reflexes. It produces more severe prolonged respiratory depression as compared to thiopentone. There is no muscle relaxant property. It is a very cerebroprotective activities there, but does not possess anticonvulsant activity. Rather, on the opposite hand, myoclonic jerking, muscle twitching can be seen sometimes. It's the intravenous anesthetic of choice for day care surgery. Also it's a great choice drug for sedation in ICU. It's also a great choice drug with malignant hypothermia for total intravenous anesthesia. Now I'll be sharing your slides also, and meanwhile you can give an explanation.
Sure, thank you. So, yeah, let's just get to let me just see which slide you're going to be on. Perfect.
We have from after this only.
Yes.
Yeah, I think from here
Yes.
we have.
Perfect. Yes. So I mean, propofol. It's it was around the mid 1970s that it was initially developed, and the sort of magic of propofol is that it's a lipid emulsion. So the propofol is suspended in a lipid mixture, and we know that obviously the target is the brain, which is lipid. So it makes propofol incredibly lipid soluble, which means it has a very rapid entry into the brain, but at the same time, it works on concentration gradients very well. So the minute that you stop giving the propofol and the concentration in the blood starts to drop below the brain, the propofol diffuses out, and then it starts to diffuse into what we call the poorly perfused tissues. So that is the muscle, the bone, the fat, etc. So it's got a very, very predictable pattern of action, and we know that it works on GABA receptors. So that is a receptor that's intrinsically, obviously, that we have. And what that receptor does is once it's activated, it opens and you get conductance of chloride across the membrane. And it basically causes hyperpolarization. So it stops the membrane from being able to be depolarized, and it causes loss of consciousness, what we colloquially call sleep. But as I showed in one of the videos that I did on the channel, it's not quite sleep as we know it, but it's loss of consciousness via the GABA receptor. But because, again, as I say, it's so lipid soluble, it only binds to that GABA receptor when there's a very high concentration. So as we say, it's got a very rapid and smooth recovery, and it's completely eliminated within 4 hours. So day case surgery, I mean, the longest propofol infusion surgery that I've been a part of was about 16 hours, a long neurosurgical case. So you can do that, you know. And I mean, that patient obviously went ventilated to ICU, but I've done a scoliosis surgery for 12 hours in a 12-year-old on propofol, and we extubated her at the end. And it took about 30 minutes for her to wake up after the propofol infusion. And it's a great drug for, especially in our setting, white or Caucasian women who are middle-aged, who have a high risk of post-op nausea and vomiting. So it is an antiemetic. It also is an antipruritic, so a very low dose propofol infusion will eliminate pruritus or itching from opioids, for example. And even patients who are in the ICU or who are vomiting for, other reasons, a low dose propofol infusion will often reduce their nausea and vomiting. And then, as you show there, Radhika, on that graph, if you just go one slide back that we were on, the context sensitive half-life is stable. So what it means is that whether you give an hour or 8 hours of propofol infusion, the wake up time is pretty stable. I say to people, on average for an adult, about 30 minutes. And if it's a child under 10, it's about an hour. And that's why we love it, because it's so predictable with this rapid offset. So then, as you show, though, there obviously are side effects. It's propofol. Yes, thank you. So the biggest issue that patients complain about for many years is pain on injection. So the first formulations of propofol, the lipid molecule that it was in, was a very, very long chain. It was a very short chain, very, very short fatty acids. And it burnt a lot. So Diprovan, the original, it burns. So the new products, predominantly from Fresenius, Propoven, has got an MCT and an LCT formulation, so medium chain and long chain triglycerides, and it burns much, much less on injection. If you give a big bolus of propofol, they will become apneic. They will become deeply sedated or anesthetized. It can cause a drop in blood pressure. So a big bolus of propofol is not for somebody who's unstable or a cardiac patient or anything like that. Mitochondrial disorders. So there are very rare mitochondrial issues where propofol can cause a lactic acidosis by inhibiting mitochondrial metabolism. So it's a tiny percentage, but in those instances, propofol is contraindicated. But for all other problems with volatiles, so malignant hyperthermia risk, muscular dystrophies, myopathies, etc., propofol is the go-to. And then the very last one, I just want to mention, Radhika, propofol infusion syndrome. It's a phenomenon that we discovered in the ICU when we were using propofol in quite high doses, especially for sedation in children. So it's this issue, it's a lipid. Now, to flood a child continuously with a high dose lipid infusion is almost, imagine giving high dose TPN. So it's not the hypotension side effects. It's that this accumulation of the lipid causes mitochondrial dysfunction, and that then causes lactic acidosis and cell breakdown. So for children, we don't run propofol for longer than 72 hours, and we don't give it in high doses anymore.
Okay, this one.
But it's a great drug. So that is the genetic susceptibility of mitochondrial disorders with propofol.
Mitochondrial, yeah, okay.
Yes, so it gets right, that lipid diffuses right into the mitochondria. But what's great about it is, as we said, besides for that condition, you can give a propofol infusion to pretty much everyone else. There used to be a worry if you were allergic to eggs because of the lipid emulsion, but that's no longer an issue. So a true allergy to propofol in the current formulation, I have not heard of. And then if you go to the next slide, its real sort of amazing impact is because you can now forego any volatile, any gases except oxygen and air, and you can run total intravenous anesthesia by pumps, and then the modern version being target controlled infusions. And this is where propofol's use was, sort of half and half. We would use a lot of volatile propofol to put you to sleep and volatile to keep you asleep. But now a lot of people are using just propofol infusions for the vast majority of their practice.
Great. That's a great thing. What about this one?
So this is the pharmacokinetics behind it.
Yeah.
Yes, so this is what we call the 3-compartment model. So we explained that
Exactly.
V1 is the blood where I inject the propofol. It goes rapidly to the brain and then it distributes out of the brain. And we can predict that by doing, they did these experiments on volunteers and ran algorithms with computing, etc. And we now have pumps that have all of this programmed in. So I say to the pump, okay, I have a 38-year-old female whose height is 1.70 meters and whose weight is 60 kilograms. And with those figures, based on the algorithm in the pump, it will determine the dose of the induction that I need of propofol and the maintenance dose to keep her asleep. And that is now what we call target controlled infusions. And it's just basically the modern evolution using these graphs showing the movement of propofol between the brain, the blood, and the rest of the body.
Right. Nice. These are very nice explanations. Now we have some theoretical aspect about total intravenous anesthesia.
Yeah, so I mean, people like it because, again, you wake up, as I argue, with desflurane, you wake up really nicely and quickly and clear-headed. It is the same with propofol. I would argue you take a little...
It is almost affecting all the systems. All the systems are getting affected.
Yes, and so there's less nausea and vomiting. It's good for just light sedation. If you're not going to do, if you're coming for radiology or an MRI scan or a gastroscopy, propofol seems to have potentially beneficial effects on the immune system, and it is neuroprotective to the brain. So there are definite benefits to propofol infusions.
That's great. Now the indications, as you have, I think you have told them, related to these beneficial effects, I guess so.
Yes, so you can apply it to any surgery if you want, but surgeries where it really is mandatory is, as we say, anybody with the risk of either malignant hypothermia or anesthetic-induced rhabdomyolysis. So kids with Duchenne's muscular dystrophy, any myopathies or anything like that. And then certain surgeries, so for example, in neurosurgery that I do, if you are monitoring the spinal cord or you're monitoring brain function during surgery, we do, evoked potentials, both motory and sensory. The volatiles, they depress the signals so much that they can't be read. So in those instances, you have to run a propofol infusion. And then, as I say, for things like sedation, for colonoscopies, gastroscopies, you would give a propofol infusion and no gas at all.
Right. Very nice. Now we have, these are as you have already told, these are the major indications of the propofol infusions.
So as I say, for some patients, if the patient has got these indications, as I said, these risk factors for gases, we use propofol. But the other area where I do use it a lot is patients with a severe previous history of post-op nausea and vomiting. And I'll just tell a funny story that I love to tell. So I was still working in the state sector, and I had a patient, an elderly lady, sort of early 70s, coming for eye surgery. And I did my pre-med. I was still a registrar. And she said, "Oh, doctor, I get the worst post-op nausea and vomiting." And I said, "So, okay, ma'am, has anybody ever told you about something called propofol?" And she's like, "No." So I said, "Okay, trust me, I'm going to try something different and you won't have nausea and vomiting." And, she looked at me as if to be like, oh, she doesn't believe me. And I ran a propofol infusion for her, gave her no gas. Obviously, I gave her our other antiemetics. And when she woke up in recovery and looked at me, her exact words were, "Doctor, you're a wizard." So she felt amazing and had no nausea. So it does work. If you've had severe nausea and vomiting before, tell your anaesthetist to give you a propofol infusion, and it makes a huge difference.
Right. That was a very wonderful example. Now, these are some no things, I think so. There's one,
Yes.
You tell us about this.
So, I mean, the most important one is, again, if they've got a mitochondrial myopathy, propofol is contraindicated. And then just, think about it. If the patient is elderly, if they've got a mitral stenosis, if they're unstable, or if they're a trauma patient, propofol might not be the best idea. So I always say, especially the younger anaesthetists, they're very keen on the pumps and the algorithms and things. But I always just say, remember, you're not treating a pump, you're treating a patient. So you need to look at your patient clinically and say, can they tolerate a propofol infusion, And then you need to also think about, do I have the right pumps and the right syringes? And, to be a little bit flippant, it's a pain to crack open so many propofol amps. In a 12-hour surgery, if you don't have the nice big 50 ml ampules of propofol, you are cracking open amps every hour. So, it's a lot more manual work, I'll say. You've got a pump for propofol, you need to make sure it doesn't tissue and all of that. So just keep those practical points in mind, and don't go gung-ho into just running propofol infusions for everyone, because it's not always better, I don't think.
Okay, nice. That's a good information. Now, this one is that it should be well monitored. Then we have disadvantages of total intravenous anesthesia.
Yes. So as I said, it needs more monitoring. So the biggest issue, number one, and we talk about it a lot in anesthesia, Radhika, is awareness.
Right.
So, that is where, I don't know if there was a movie with Jessica Alba. It did terrible things to the anesthetic community called Awake, where in the movie she's having surgery and she's totally paralyzed and she feels everything. And with volatiles, because we've used them for so long, and because MAC is such a well understood concept, the risk of having awareness with a volatile is very, very low. Now with propofol, we've got these pumps and they give us suggestions, but those suggestions were based on only about 100 young, healthy male volunteers. So with propofol, you need more monitoring, especially for risk of awareness. So you need a depth of anesthesia monitor, something like a BIS or a processed EEG or an entropy monitor, a Massimo, anything like that. And the second thing that I do, because maybe I'm just a little bit old-fashioned, is I always give these patients midazolam intravenously, just to reduce the risk of awareness, make sure it doesn't happen. So that's the first issue. It is more, you need more monitoring and you need pumps. You need to know how each pump in each hospital works. So our registrars train across 4 different hospitals or 5. I work at 3 different hospitals currently. We don't always have the same pumps. So unfamiliarity, a big issue is that you set the pump incorrectly. So you set milligrams per kilogram instead of micrograms per kilogram. And you then have issues where maybe for example, we now have 1% and 2% propofol. And if you're not aware of that and you put the wrong percentage concentration in, it's a totally different ball game. And then, as we said, the next point is occlusion. If you occlude the pump or it extravasates, not only can propofol be very irritating to the tissues, but your patient starts to wake up. And you don't understand because they're under the drapes. The classic sort of horror story is ENT surgery, because we use a lot of propofol there for airway, vocal cord. You've got a patient who's fully draped, you've got a shared airway, and your propofol drip tissues or it blocks, and the patient starts to cough. It gives me chills as I think about it, because now you're trying to troubleshoot a pump, a drip, etc. So I always say to people, if you're going to be running a long total intravenous anesthetic, you make sure you've got a good caliber gelco in a well-running vein, and maybe think about having a backup. And then the cost is also an issue. You need to buy the pumps and all of that. So, it's not in the state sector, for example, we're probably doing half and half. In the private sector, where cost isn't such an issue, there are some of my colleagues who are doing 100% TIVA,
Okay, that's a great.
But it isn't the magic, it's not the cure all to you. I still, as I say, I do TIVAs when I have to for my neuro cases, for sedation, etc. And as I said, with propofol, people now I think are becoming more familiar, but I strongly encourage everyone, and if you're not in an academic setting and you're a GP or you're a sedationist or someone like that, you need to do some sort of propofol, TIVA, TCI course. And you can do them online, you can do them in person, and they take 1 day. And what the most critical thing they show you is a wide variety of pumps and how to program them and how to troubleshoot the pump. And once you've got that down, then I recommend in a controlled setting to start doing TCIs on younger, healthier patients. And then, you get a feel, because the pump will tell you, for example, that the wake up time is 40 minutes. But, anesthesia, we always say, is a science, but it is an art. I can get a feeling just from how much propofol the patient needed, how much fentanyl they needed, that no, this one will wake up quickly, etc. So you do need to get more familiar with it. But the wake up is great, and the post-op nausea and vomiting reduction is brilliant.
Right. Thanks for this elaborated information about this whole propofol and TIVA.
You can see anesthetists love propofol.
Right. So that was a great information. Briefing about etomidate. It does not interfere with cardiovascular functions. It's the agent of choice for aneurysm surgeries and cardiac diseases. It causes minimal respiratory depression. Maximum incidence of nausea and vomiting is seen with the use of etomidate. It can also produce myoclonus. Injection is painful. It results in thrombophlebitis many a times. It can lead to adrenocortical suppression and vitamin C deficiency also. So, what anything else you would like to add about it? Etomidate.
Yes, sorry. So I love etomidate, but it's got problems. Okay. So, it's funny how I always describe we have emotional reactions to drugs. So etomidate, the blood pressure doesn't budge. If it's 110/60 or if it's 80/40, it'll stay there. If the heart rate is 100, it'll go up a little bit. So it's great from a hemodynamic point of view, stability point of view. Okay. And at Baragwanath Hospital, where I was a consultant in government for electroconvulsive therapy, etomidate was the anesthetic of choice because it doesn't suppress seizures so much. The problem with it is twofold. Number one, it causes severe post-op nausea and vomiting. So if you've got a patient who's got a history of post-op nausea and vomiting, etomidate can make your life terrible. And the second issue we discovered is that it's got a side effect of inhibiting 11 beta hydroxylase. So in patients who are chronically ill, who have adrenal insufficiency, it can cause an Addisonian or adrenal crisis. So and we figured that out the hard way, unfortunately, because it's so hemodynamically stable and it's got very similar pharmacokinetics to propofol, because it's also now a lipid emulsion. We were using it to sedate patients in ICU because it doesn't have the hemodynamic effects. And they all started dying. And they figured it out that they were having adrenal crises. So you can't give it to patients who are critically ill, and you can't give it in a long-term infusion, unfortunately. So there was talk, pre-COVID, I was reading a bit of the pharmaceutical company literature that they are really trying to figure out a formulation or a way to make etomidate without that adrenal issue. And then it'll be an interesting arms race, because then with its hemodynamic stability, it will be a runner with propofol. So I'll be interested to see if it happens. But I haven't heard anything about it recently, unfortunately.
Okay, so that's an interesting thing. Now a word about the slow-acting agents. Amongst the benzodiazepines, the new agent is remimazolam. It's a new drug with rapid and short acting than midazolam. It is used to induce sedation for short procedures. So these agents are used for causing sedation and enterograde amnesia. Anything else about benzodiazepines?
Yeah, so we don't use them for induction of anesthesia so much anymore, except I used to use it in cardiac surgery for patients who are going on bypass. And that's because of the hemodynamic stability of it. But in that instance, we were doing a very unique induction. We were using high doses of fentanyl, so 500 micrograms to 1 milligram of fentanyl with midazolam. Where I use it commonly is actually twofold. Is I use it as a pre-med in patients who are anxious, so 7.5 milligrams orally, 45 minutes before their surgery, or I use it intravenously after I put up the drip, and I give 2 to 5 milligrams of midazolam as part of my anesthetic. It just helps with anxiety, and the amnesia that it causes helps patients to not really remember the bad parts of their hospital experience. And then you can give it orally, mixed. I don't give it on its own as a pre-med to children, because kids can have a paradoxical reaction to midazolam. They can go completely hyper, as well as the elderly. So I don't give midazolam to anyone over the age of 70 because of that same reason. So just be careful in children and the elderly with midazolam. But it is a nice hemodynamically stable drug. But remember, if you combine it with an opioid, with fentanyl, or with propofol, you will get apnea. It will cause respiratory depression. And that's where sometimes people get caught out, is they don't fully appreciate the effects of the combination of midazolam with something else.
Right. That's a great information. So we'll talk about opioids only. Fentanyl, L-fentanyl, sufentanil, remifentanil. They are the opioids that are used in anesthesia. They're 100 times more potent than morphine. Sufentanil is the most potent opioid. They have a very strong analgesic activity. Fentanyl is being used with droperidol for neurolept analgesia. Now we have two terms, neurolept analgesia and neurolept anesthesia. So first, the combination of fentanyl with droperidol, that is neurolept analgesia. If nitrous oxide is also added, the combination is known as neurolept anesthesia. So these agents can lead to post-operative muscle rigidity, and L-fentanyl is also used for daycare surgery for total intravenous anesthesia. Remifentanil is the shortest acting opioid due to its metabolism by esterase. What else would you like to tell us about these
Yes.
opioid drugs?
So if you look at clinical practice, the opioids we use most commonly, the short-acting opioids, as we said, would be fentanyl, sufentanil, remifentanil, and L-fentanyl. And then the long-acting opioids would be morphine, pethidine, and oxycodone. So obviously, we know that the short-acting opioids, they're incredibly potent. So they work, for almost any analgesia. And like I say, in high doses, you do what we call a cardiac anesthetic, where you can have open heart surgery. The problem with them, obviously, is they cause respiratory depression. Fentanyl and remifentanil and L-fentanyl, all of three of them, if you give it in a very fast IV push, you can get chest wall rigidity. And I've had one instance of chest wall rigidity from remifentanil that only relaxed with the use of rocuronium, of a muscle relaxant.
Rocuronium.
But they are the mainstays of short-acting analgesia for short procedures, for induction of anesthesia, etc. If you're having a G-scope or any biopsy, you'll get a small dose of fentanyl or sufentanil. And then remifentanil is used most oftenly as an infusion, and it has to be used as an infusion because it's so rapidly metabolized. It's actually what we call, its half-life is context insensitive. Whether you give remifentanil for 1 hour or 10 days, it's out of the blood in 7 minutes, regardless of how long you've been giving it for. So it's great, but it's a double-edged sword, because if the remifentanil infusion stops or finishes, your patient has got no analgesia on board in 7 minutes' time. So you need to give morphine with it. But we run in theater, for example, when I'm doing the big neuro cases, I run propofol with remifentanil. And there's now a new model called the Elefelt model for propofol infusions. And it actually takes into account that you're using remifentanil, and it understands the synergistic relationship between the two. And so it allows you to then lower the propofol concentration. But as I say, remifentanil, it's not a long-term analgesic, and that's where people get caught out.
That's a very nice information. A very good clinical pearl again. So this was all about the briefing of the agents. Now I'm going to talk about pre-anesthetic medication. So and then we'll take the environmental impact in the end.
Yeah.
So pre-anesthetic medication, it refers to the use of drugs before anesthesia to make it safe and very smooth, very pleasant. The aims are to relieve the anxiety, supplement analgesic action, and also potentiate it, decrease the secretions, vagal stimulations, antiemetic effect, decreased acidity, and the volume of gastric juice. Accordingly, the agents used are sedative anti-anxiety agents like benzodiazepines, especially diazepam, and then in promethazine is also used as it is an antihistaminic agent. It has a sedative, antiemetic, and anticholinergic property. Among the opioids, morphine and pethidine, they allay the anxiety and apprehension of the operation. They smoothen the induction. Then fentanyl is mostly injected IV just before the induction. Anticholinergics used are atropine, hyoscine. Then we have other drugs like hyoscine. In addition, it produces amnesia, antiemetic effect. Glycopyrrolate is very potent drug, longer acting drug. Anti-secretory action is more marked than atropine. Then neuroleptics, we have chlorpromazine, triflupromazine, haloperidol. Intramuscular, they are occasionally used in pre-medication. And then we have H2 blockers, proton pump inhibitors like ranitidine, omeprazole, pantoprazole. Prevention of stress ulcers is another advantage. And last class of drugs is antiemetics. Metoclopramide is used intramuscular preoperatively. Combined use of H2 blockers and metoclopramide is very effective. Domperidone is very effective. Ondansetron is actually selective for 5-HT3 blockers. It is highly effective in reducing post-anesthetic nausea, etc. So what are your experiences with this pre-anesthetic medication?
Yeah, so I think, there's lots of drugs available, Radhika. So the way that I look at it is I look at what am I trying to achieve with the pre-med. And there's only really a few small things that you can achieve. The most common one is angiolysis. So the child or the patient is anxious. And for that, the most common one that we use would be a benzodiazepine. So either midazolam or diazepam orally. And then in instances where the oral route is not possible, those are available IMI or IV. And then again, in certain instances, you've got the use where I use ketamine as a pre-med orally in high doses. You need to use it in 10 milligrams per kilogram. It tastes terrible, so you mix it with something small and sweet. And for children, it doesn't cause respiratory depression, but it causes them to be quite nicely relaxed. And for cardiac patients, as I said, for example, if I have a child with a VSD or a tetralogy of Fallot who's coming for surgery or coming to cath lab and they don't have a drip, I will give them an oral ketamine pre-med to facilitate smoother intravenous access. But most commonly for angiolysis, it'll be the benzos. Some patients will be in pain preoperatively. So then the point of your pre-med will be analgesia. So that could be ketamine, that could be an opioid, that could be something like dexmedetomidine, Precedex, an alpha-2 agonist, Then in some patients, burns patients, that might be secretions, that's the issue. Or in neonates, they might be bradycardic, or, then you're going to give glycopyrrolate or atropine for secretions, for to give them a tachycardia to prevent bradycardia. And then some patients, we at Barra had a psych unit that used to do ECT, electroconvulsive therapy, and a lot of those patients were severe, either schizophrenics or patients with catatonia. So in that instance, you would have to give those patients haloperidol or droperidol IMI before they could come to theatre to facilitate putting up a drip. So IMI pre-meds are rare, except in the odd, like I say, in a child, in a cardiac child, or in somebody who's truly wild and uncooperative. But most of the time, you're going to be getting either angiolysis, or we're going to give you something to prevent nausea and vomiting. We're going to give you something to dry up secretions. Those are the three most common ways that I can think of us using pre-meds.
So we use only few meds in normally most of the patients, and in rare
Yes.
cases, we have to use more meds.
Yes, exactly. So most patients only need one pre-med, but some patients will need a combination. So midazolam with ketamine works well because the midazolam offsets the hallucinogenic and the dissociative effect of the ketamine. So those two synergistically work well. Dexmedetomidine, Precedex, often works really well on its own, but in combination with a small opioid, it can work even better. So they do work well synergistically. But it's only rarely in patients who are either getting repeated sedation, where their liver enzymes are induced for whatever medication they're on, or they're very agitated, or they're a psych patient where you would need like multiple pre-meds,
Yes. Now I would like you to tell us about this environmental impact.
Yes.
Yes.
So as you put up the slides, Radhika, just to put it in context, so there was an article that I read that's shown there. Scotland is the first country to ban environmentally harmful anesthetic. So this is desflurane that was banned by NHS Scotland. Now, being such a big fan of desflurane, I was quite irritated when I saw this, and I was like, but why? And their argument was that of the greenhouse effect, and if you go to the next slide, of what they are calling the CO2 equivalent of desflurane. So they're saying 1 hour of surgery using desflurane is equivalent to driving roughly 300 kilometers. Okay. However, I think that's a bit dramatic, okay, because they're saying that desflurane is so much worse than sevoflurane or isoflurane because it hangs around in the atmosphere for longer. All right. So if you go to the next slide,
Yes.
the sort of anesthetic carbon footprint, okay, if you look at the difference between a GA and a spinal where no volatile is used, the difference is minimal if you look at that graph. So my argument is, number one, climate change due to man-made carbon dioxide is still a controversial topic and issue. And, in India, for example, you guys have coal power stations and, those things, and I have no problem with that. But to say that we must stop using a clinically proven safe anesthetic agent because of CO2, I think you have, the saying is extraordinary claims require extraordinary evidence. And by using a volatile, you increase the carbon footprint by maybe 4%. And what these people have forgotten, and there's heavy debates. I don't know in your areas, but in my anesthetic community, there've been quite sort of, rough and tumble debates about TIVA versus volatile in the environment. And some people can get dogmatic about it. And my argument is, okay, the hospital is built with fossil fuels. The hospital is run on fossil fuels, electricity and all of that. The plastic, the latex, the single use, the disposable everything. By the time you've done all of that, are you really going to pick on my desflurane and say that's going to kill the polar bears? I just find it extraordinary, And that was the point that I don't know what you feel, but that was the point I was trying to make is that, yes, I'm not saying they're not greenhouse gases, they are. But the tiny amount of volatile that gets released compared to when a volcano erupts or compared to when Elon Musk shoots a rocket into space is just minimal,
That's a good argument.
So
Okay, what
the
about
point that I was trying to
this
make is
one?
that as you look here, human versus naturally produced CO2, the vast majority of CO2 in the world is produced by living, breathing organisms, by the oceans, and by volcanoes. And I just said that I refused, and this was encouragement I gave to my colleagues and even to the pharmaceutical industry in South Africa. I said, you know, unless you're showing me patient benefits, global warming, climate change should not come into clinical anesthesia. And I think Scotland jumped the gun, maybe trying to look a bit virtuous or whatever. But if I was a clinician in Scotland, I would be very cross because a very safe, rapidly titratable volatile has been removed, and there's very little evidence to prove that it should have been. And then if you go to the next slides, I also say don't forget about propofol. Propofol isn't made, by fairies from unicorn dust.
Okay.
Propofol. Oh, so this study here, I'm sorry, was one that I pointed to by Slingo that said the impact of these climate models has been way overstated on the anesthetic gases, and they are dismissing a lot of the sort of initial fears we had about how bad volatiles were. And then as you go down, I say, propofol is made in factories. Propofol requires fossil fuels and electricity and all of that, and it doesn't degrade. And that's the issue. And discarded propofol needs to be incinerated, and because it's a liquid, most people think you can pour it down the sink, but it's like pouring liters of oil and lard or ghee down the sink. And so it doesn't degrade. It forms toxic fat particles that are toxic to fish life. And we don't know, just as we talk about microplastics and smaller fish are eaten by bigger fish, which are then eaten by tuna and salmon, which we eat,
Yes.
we think that could be happening with propofol. And up to half of all propofol that's manufactured gets wasted. And that's the big environmental issue. So its carbon footprint is less, but its environmental impact, we don't know. And that was just the point that I wanted everybody to be aware of, is a carbon footprint doesn't equal environmental damage. And so the jury is still out on whether volatiles or propofol is better for the environment. But what's certainly true is that as the anaesthetist, the clinician, we are deciding for our patients, not for the environment. That's for the politicians.
Right. That's one aspect, but we should be aware of all the aspects, right?
Yes, yes. So as I said here, clinical decisions should be made by us. The patient comes first. There's only trade-offs. If we get rid of volatiles, then what are we going to do about patients with mitochondrial myopathies? If we get rid of, if we anti-propofol, what are we going to do about nausea and vomiting and about neuromonitoring? So I think just as, in anything in life, the politics, religion, the culture, everything swings one way and then the other, and it comes back to the middle. In my practice, and what I tell people is just be in the middle. Use propofol when it's appropriate and use volatiles when it's appropriate. And I have a very happy, thriving, safe practice by not being dogmatic about one or the other.
That's a very nice point. And this is our last slide of the day.
Yes. So as I said, I just found this really funny. Most governments, if you look wherever you live, where I live in South Africa, there's people living in shacks and on the streets, but they suddenly tell you that if they tax you more, they can change the Earth's temperature. So just be a skeptic when the government tells you that by paying more money or an extra tax, you're going to change the world and fix things. Because if money fixed all the problems, then there wouldn't be homelessness and all the problems we have. So that's my little cheeky anecdote for the end of the show, Radhika.
Yeah, that's a nice anecdote. And
Brilliant.
with this, we end up today's discussion. Anything would you like to add up before we end up on the final note?
No, I just wanted to say thank you so much. It was so much fun to chat to you. I hope that
It was a highly informative, very
thank you.
interesting, and very knowledgeable, educative kind of a discussion. I thoroughly
Thank you.
enjoyed. Not a single point I was like it was so interesting, and all the examples were so wonderful because they were the clinical pearls that you shared
Yes,
from your whatever practice experience that you have been going through. So they were
absolutely. Yes.
quite wonderful. So I really thank you for
Thank you.
giving me this opportunity of making yeah, of having you as a guest here on my podcast.
Excellent.
And anything, what else would you like to say about it?
No, so the last thing I want to say is just I'm going live at 7:30 Central Africa time, so South Africa time on my channel, Dr. Tristan Anesthesia Tutorials on YouTube. And we're going to be talking about cardiac anesthesia with a very, very dear friend and colleague of mine. So if you're interested, please come across to my channel and you'll get 2 hours of cardiac anesthesia as you've never heard it before. And
Sure.
Radhika, like, share, and subscribe. Is pharmacology difficult, everyone? Thank you so much.
Thank you so much. All the links about all the socials and all the links are shared in the description box. You can
Brilliant.
follow Dr. Tristan on the YouTube channel, and other links I have shared on the Facebook also, on the Instagram. Then I think TikTok is not, it may be like in other countries, it is not here.
Yes.
So I'm not sure whether I've shared the link or not. I will do
Okay.
it. I will do it. And other more links, Facebook and Instagram and X. Yeah,
Yes.
those links are
Yes.
definitely shared in the description box. So
Thank you
you
so
can
much,
just
Radhika.
definitely follow for more anesthetic knowledge, more clinical
Awesome.
pearls, and more real life examples that Dr. Tristan has to share with all of you. And definitely watch on his channel. There will be a cardiac anesthetic session with one of his colleagues, following this one only. So the time difference can be there, but still, it would be highly educative and knowledgeable. I'm sure about it. So with all this, till the next time, thank you for
Thank you.
listening. And we had a nice audience in live also. So I don't know
Excellent.
whether they have any questions, but we are running a little short of time. So
Yeah.
whatever questions you can put up in the comments box, and definitely I'll
Brilliant.
be answering them with the help of Dr.
Awesome. I'll
Tristan.
also have a look and I'll try and answer them as well, Radhika. Thank you so much.
Yeah.
Have a wonderful evening.
Thank you. Thank you so much. Thank you.
Thank you. Good night.